MSC is passionate about going beyond just treating acute conditions after a hospital stay at home. We are invested in wellness and supporting patients in as many aspects of their healthcare as we can. Because of this commitment, we launched our diabetes division in 2021. Here we supply life-changing CGM supplies, including readers and sensors, insulin pumps, pump supplies, and more. We can even provide insulin and your other daily medications through our pharmacy. Our focus is to provide superior patient care combined with the latest CGM technologies to ensure the best outcomes for our patients. You have our commitment to be your trusted local source for CGM products and diabetes care. To learn more about CGM and our diabetic supplies, please visit us at medicalserviceco.com or call 844-90-MY-CGM.
What another great lecture. Thank you, Dr. Ye. Our next presentation will be provided and presented by Dr. William Noah. We are pleased to welcome him to our educational forum, and we are truly grateful for his participation. Dr. William Noah grew up in Tennessee, where he completed his medical training and was chief resident. In addition, he was awarded a Parker B. Francis Fellowship during his pulmonary fellowship at the University of Utah. Noah eventually returned to Tennessee in 1992 to start his own pulmonary and sleep medicine practice, Sleep Centers of Middle Tennessee. Since then, SCMT has grown into one of the largest practices in the United States. Beginning in 2006, Dr. Noah pioneered remote patient monitoring for sleep by requiring modems on all PAP patients. His 3-month adherence data helped later sway CMS to require adherence for reimbursement. When other programs had shut down during the pandemic in 2020, Dr. Noah developed a way to diagnose and treat patients with OSA across Tennessee and 6 neighboring states. For those efforts, he received the Visionary Award from the Tennessee Public Health Association. Currently, Dr. Noah is the CEO of SleepRes. Thank you again to Dr. Noah for participating today. Please make sure to submit your questions by clicking the Engage tab above the presentation screen so Dr. Noah can provide answers after his lecture. Also, be sure to complete and submit an evaluation following each presentation. So without further ado, here is Dr. William Noah to present his lecture, Manipulating the PAP Circuit to Increase Adherence.
Hello, I'm Dr. Bill Noah, and I'm a sleep medicine specialist. And today we're going to talk about the history and future of PAP therapy, basically trying to provide a deeper understanding of the PAP circuit, because I believe, as we found in our practice, that as our sleep techs, our respiratory therapists, and our providers understand the circuit better, we can provide better care for our patients, provide more comfort, and the long-term goal is to get long-term adherence. So we're going to start off with a couple questions, but first, my conflicts of interest. Well, I do have conflicts of interest specifically with this lecture because I'm the inventor of the VCOM, which I'll be mentioning towards the end of the lecture, and I'm also a part owner of SleepRes. So let's do some questions. Let's kind of see what you know about PAP therapy and CPAP machines. Number one, a continuous positive airway pressure CPAP device is best referred to as a flow generator, a pressure generator, a resistance overcomer, a flow reducer, or a resistance reducer. Now, when I've given this in meetings, almost everyone picks a flow generator. And up until probably a year or two ago, I would have used the same term. But technically, a CPAP device is not a flow generator. It's a pressure generator. Any fan is actually a pressure generator. It creates pressure on the surface of the blade, and that's what creates the flow. And you say, well, does it matter? Well, I don't know if the chicken or the egg came first, but I do know that pressure always precedes flow, and we're going to talk more about that. And the misunderstanding of it has led to, I think, a lower level of care for our patients. Question number two, patient is doing well on AirFit P10 nasal pillow mask, the most common one sold in the US, at 16 centimeters after recently having his pressure increased from 13 centimeters. However, now, since he's increased his pressure, his humidifier chamber becomes empty an hour before he awakens, and it's causing nasal symptoms. He wants this fixed. Which of the following will resolve this problem? Will you switch him to a nuanced nasal pillow mask, switch him to a full face, switch him to a Brevida nasal middle, and put the diffuser in place, decrease the room temperature, and increase the room temperature? Well, I don't think anyone's got this right the first time. It's really simple. The reason that this patient's humidifier chamber is becoming empty is because we increased his pressure. As we increased his pressure, we increased the exhaust flow, or what you call intentional leak. There's more air coming out the little holes. Okay, and as you do that, then he's emptying his humidifier chamber earlier. How can you fix that? Well, switching to a full face or a Boveda will not, because they have similar exhaust flow to an AirFit P10. Decreasing the room temperature, in theory, could help because it takes less moisture out, but it's not going to fix this. Increasing would worsen it. The answer is switching to a nuanced nasal pillow mask, because Philips masks in general have less exhaust, and particularly the nuance has the least exhaust currently on the market. And if you did that and he's on high pressure, it's no problem. This would resolve his problem, and he would probably be a much happier patient. Number 3, Dr. Smith is high maintenance, but refers many patients to your DME office so you tolerate him. His titration study had to be aborted after 3 hours. I couldn't breathe, he said. He's 6'3", but he's thin, but he's really retroactive. And you ordered, or someone ordered APAP 6 to 12 centimeters, and you gave him a nuanced nasal pillow mask. He calls your office after 2 days and says he only can last an hour. Well, therefore, EPR of 2 was added. The following morning, he shows up to your office and throws his equipment on your desk. Says, I get so anxious, I quit after 15 minutes. Either sedate me or take this back. Your best response is the following. 6-foot wimps need sedating. Recommend clonazepam. If he can't handle that pressure so low, I'll show empathy and encourage him to keep trying. Make him feel heard. Decrease his APAP all the way down to 4 to 8 and increases EPR to 3 until he can tolerate, and then increase. Number D, just make him toughen up. Go ahead and increase the pressure, 9 to 12, and turn off the EPR. And E, switch to a Vitera full face mask. Well, the answer is D. You've got to increase his pressure. And the reason is this is classic rebreathing. This gentleman is suffering because we've given him not enough exhaust flow, and he can't clear his CO2. He's 6'3", so he has a high expiratory flow rate, and it's exceeding the exhaust flow rate at low pressures, particularly of the nuanced nasal pillow mask. The last question, remember, it helped because it had decreased exhaust. So that's great at high pressures, but at low pressures, it's a problem, and he's rebreathing. And of course, when you added the EPR, you just dropped the pressure from 6 to 4. That clears the gas, because it's expiratory pressure that clears the gas. So you made it worse. That's why I only went 15 minutes and he shows up. So the answer for this is he needs increased pressure to start with. Number 4, which of the following is most effective in the treatment of hypopneas? IPAP, EPAP, IPAP, but only after sufficient EPAP has been supplied to prevent complete airway closure, apnea. 4, IPAP, but within a minimum of 2 to 4 centimeters increase over EPAP and mean airway pressure. And when I've given this question to large groups, the answers are always 3 or 4. But the real answer is 2. It's EPAP. EPAP, yes, the most effective in the treatment of apneas. It's also the most effective in the treatment of hypopneas. EPAP is therapy. And we're going to go into this in quite detail in just a little bit. So remember, EPAP is a therapy. Yes, I know the guidelines say titrate up the EPAP, to get rid of the apneas, and increase the IPAP to get rid of hypopneas. But EPAP going up by itself would be better. Question number 5. During the expiratory phase, which interface maintains or provides the highest pharyngeal pressure? Now, this is important, particularly for respiratory therapists and those who are, fitting masks and doing all this, because treatment therapy is the pharyngeal pressure, not the machine. It's what's the pressure in the pharynx, and of course also in the chest to increase functional residual capacity. So which one will have the highest expiratory pharyngeal pressure? Full face, nasal pillow with large cushion, nasal pillow with small cushion, or under the nose, any size. And unfortunately, this isn't gotten right very often either. And the correct answer is a nasal pillow mask, particularly with a small cushion. The smaller the cushion, the more resistance. Yes, as you breathe in, you're going to drop inspiratory pressure with resistance, which you're going to learn a lot more about today. But when you breathe out, you build back pressure crossing the resistance, just like a nasal EPAP device. And so that's why nasal pillow masks require less therapeutic pressure. In other words, someone on 12 with a full face might actually only need 9 or 10 with a nasal pillow mask, depending on the size of the cushion. So these are all things we can do to help our patients. And finally, the last question. Patient is doing well on APAP 10 to 16 with EPR 3 and a ResMed M20 nasal mask with a P95 pressure of 13. His wife insists his treatment is too loud. You assure her you can help. Which of the following, I need to change that, will not decrease the noise in the PAP in the patient's PAP circuit. So think about that. 4 of these are right. 4 of these will decrease the noise. 4 of these interventions you could do to help this wife with the noise, 1 of them won't. So which one is the one that won't? Turning off the EPR? Turning off the EPR will decrease the noise because you're lowering IPAP. You're lowering the peak IPAP pressure, inspiratory pressure, and therefore you're lowering the motor noise and the actual exhaust flow during inspiration. And so therefore you're lowering the noise. Switching his nasal N20 mask to a nuance mask. Well, you probably have figured this out because the nuance has less exhaust flow. It's going to be quieter, right? Also, the nuance is a nasal pillow. So therefore it's going to need less pressure on auto PAP because of the resistance in the pillow cushion. Switching him from a nasal mask to a ResMed will not, from a nasal mask to a full face will not decrease the noise. It might actually increase it. Changing his 15 millimeter tubing to a standard 20 will decrease the noise because for a 15 millimeter tube, the machine has to generate more pressure because of the pressure drop across the 15 millimeter tube. Therefore, the motor is going to make more noise. And because of the narrow diameter, you're going to have a higher velocity in the tube, which is going to create more noise as well. And finally, adding a VCOM device to his PAP circuit. Yes, VCOM is great at reducing noise, and you're going to hear more about that later on. All right, so that's the kind of starter questions. And let's get back to some basics and see where some of this came from. So pressure and pressure gradient. When we talk about pressure on a CPAP machine, we're talking about a gradient. If you look at centimeters of water, the sea level normal barometric pressure is 1,034 centimeters of water. Okay, and so pressure is a gradient. So if you have them on 20 centimeters of CPAP, well, then you might have a sea level of 1,054 compared to 1,034 out in the room. Now, pressure is a force. Pressure is the force of the gas molecules contacting the wall. Think of it this way, between pressure, flow, and resistance. Pressure is what's adding energy into the system. Resistance is what's taking energy out. And flow basically does what pressure and resistance tells it to do. Flow is just trying to equalize pressure. It's just trying to make peace between a couple of pressures. Now, there's 3 pressures in the circuit. There's the room pressure out in the room, which we usually equate as 0, even though at sea level it might be 1,034 centimeters. We call it 0. There's the circuit pressure. That's the pressure between the exhaust in the circuit and the machine. Okay, and then there's the airway pressure, which is the pressure in the pharynx and in the lungs, and that's the therapy. And those are the ones we'll be dealing with. Now, how is PAP, or positive airway pressure, therapeutic for OSA? Well, there's 2 principal actions. Number 1, we all know that it splints the pharyngeal airway open. It's like a splint. It holds it open as you breathe so it can't collapse or obstruct. But there's also something called increased functional residual capacity. Functional residual capacity is the total volume of air in your lungs after exhaling a tidal breath. So breathe in and breathe out and relax till you're comfortable. The amount of air in your lungs at that point when you exhaled is your functional residual capacity. So when you go on CPAP, it increases that because of the pressure. In other words, when you exhale, there's more air in your lungs at the end of exhalation, and that pushes your diaphragm down, pulls your trachea down, and pulls on the pharynx and stiffens it like a rubber tube. I've got a CPAP mask here with a little tube on it. I can show you. So as you pull on this tube, you make the walls stiffer, and that is very important in treatment. We'll talk more about that. CPAP also has a third action for nasal to pillow mask and under the nose mask. It actually opens the nose and decreases nasal resistance. Other masks don't do it. For instance, a full face or a nasal mask has the same pressure on the outside of the nose as it does on the inside of the nose. So there's no effect of dilating the nose and opening it up. But you can see in the picture here, Jessica, there's nothing covering the outside of her nose, and she's having the inside of her nose pressurized. So that tends to do the same effect in the nose as it does in the pharynx. So basically, to summarize this, there's 3 sites of action for CPAP, or positive airway pressure. There's obviously in the pharynx, where it's pushing out the molecules, gas molecules, or a force holding it open. There's the functional residual capacity, pushing and pulling the lung down, pulling on the trachea and stiffening the walls of the pharynx. And then there's also the third possibility of increasing the cross-sectional area or decreasing the resistance in the nasal passage. That only nasal pillows and under the nose mask will do. So let's talk about this increased functional residual capacity, or FRC, and why it's so important. And there's tons of literature on this, but my favorite article was by Heinzer et al. It's like a group of who's who in sleep medicine authors. There's like almost everyone was a fellow at Harvard at the time, and they're all like heads of different programs across the U.S. now. But anyway, they took patients with severe sleep apnea, and they put them like in an iron lung. It's a plastic shell with their heads out, but they could adjust the pressure to change functional residual capacity in the chest. For instance, if they pressurize the shell, it would lessen functional residual capacity. If they put negative pressure in the shell, it would expand the lungs and increase functional residual capacity. And the average index needed to treat these patients was about 12 centimeters baseline. But when they increased the FRC, guess what? It dropped to 5 centimeters. So people who were being treated with 12 only needed 5 now. And when they decreased FRC, it made the pressure they needed 17 centimeters. And that's because the abdominal fat or the obesity is pushing up on the diaphragm. And most patients who need high pressures to treat obstructive sleep apnea, they're not needing that pressure in their pharynx. They're needing it in their chest to push down and help stiffen the walls. Because when abdomen's there, it pushes up and it makes the wall more floppy of the pharynx. It does the opposite. That's why gaining weight worsens sleep apnea and losing weight helps. And what's really important, that's why therapies that don't increase FRC are so much less effective than CPAP. Oral appliances, upper airway surgery, and hypoglossal nerve stimulators like Inspire, that's why they're not effective in obese patients or particularly more severely obese patients. And also remember that it's the expiratory pressure that determines FRC, not the inspiratory pressure. All right, so let's look at a little history of PAP. PAP was first recorded use that we know of in the late 1870s by Ortel that used compressed air to treat severe asthma. In a way, a hybrid of some things we did in the 80s and 90s. And then George Fell used a foot-operated bellows to ventilate patients who had opioid overdoses and try to keep them alive until they, awoke from their overdose. George Fell is much more well known for inventing the electric chair. Then in the 30s, Alvin Barrett, when he was at University of New York, used positive airway pressure to treat pulmonary edema very successfully in multiple cases. I think more great research would have been done, but he went to Harvard and got interested in psychotherapy. And of course, in the 70s, it was used extensively to treat ARDS, to try to keep people from having to be ventilated as early. And of course, in 1981, Colin Sullivan introduced the role of using positive airway pressure to treat obstructive sleep apnea. And what's interesting in Sullivan's original article, excuse me, guys, excuse me, he makes the comment that initially when people go on PAP, inspiration is facilitated and expiration is impeded. Normally, inspiration is an active thing when you have to actively breathe in, and it's like loading a spring in the chest wall. And then when you exhale, it's just the spring goes back to normal and that volume goes back out. It takes no effort. So the work of breathing when you're just breathing on room air is with inspiratory effort for normal tidal volumes. But when you go on PAP, it's like breathing backwards. Inspiration is still active, but you're actively having to resist the pressure. You see, without this active resistance, the positive pressure would just distend your lungs. For instance, if I was to take you and sedate you and then give you a pharmacologic paralytic, in other words, paralyze you pharmacologic like we do in the ICU on a ventilator, and put you on 15 centimeters of PAP, it would just distend normal lungs all the way out to vital capacity almost and just hold it there. And so someone going on 10 or 15 centimeters of CPAP, they have to resist that initially. Otherwise, it's going to augment their tidal volumes. And of course, Beverly Bishop at the University of New York at Buffalo back in the 70s when we were using PAP to treat ARDS, she did experiments showing that PAP initially increases tidal volume and increases minute ventilation. And of course, we're going to mention later, that's probably why CPAP causes TEXA. We'll get treatment emergent central sleep apnea. And these effects are worse with lower BMI. Thinner people have more problem handling this because they have higher chest wall compliance. It takes less pressure to distend their lungs, where someone who's more obese or bigger takes more pressure, more work to distend their lungs and push their diaphragm down. So while expiration is more difficult on PAP, it is the forced inspiration that is most offensive to new patients. Surveys show 20% of patients have trouble exhaling. Almost all patients have trouble with the forced inspiration when they first begin CPAP. Now, CPAP likely increases the work of breathing for most new patients. Milo et al. In this 2017 article, they were looking at metabolic rates, and they saw that when they put them on CPAP, the metabolic rate during sleep went up 14%. And they really didn't ever think about that PAP could increase the work of breathing. They, were so blinded with this whole idea of IPAP higher than EPAP, decreasing work of breathing, that they concluded that the respiratory events decrease metabolic rate. Think about this. You're having 2 or 3, sympathetic storms in response to a respiratory event, per minute during sleep. You're having all this sympathetic discharge, and you think that's going to decrease your metabolic rate? No, this is just wrong. They just didn't realize the work of breathing that's needed increased because of having to resist the positive pressure. Remember, pressure times volume equals work in joules, and pressure times flow is power in watts. So when I teach pressure, flow, and resistance and the relationship of those to our staff, because our staff can answer all those questions up front, because that's how we think through and navigate patients' complaints as problems. Everything's pretty much pressure, flow, and resistance. And these masks and these different things we use in the circuit, they all have science to them. It's not just, is this mask prettier? Is this mask softer? It's what is the science in the mask, and understanding the science can really help improve therapy. So anyway, you think of your rock, paper, scissors. Without a pressure gradient, there is no flow. When the pressure is equal in your room, there's no flow. You got a fan over here creating pressure, then it's going to create flow across the room. But of course, that air is hitting the resistance of all the other air molecules. And that's why I've had a fan across my room. I probably wouldn't feel it over here. It's about 30 feet away. So without a pressure gradient, there is no flow. Flow does not exist on its own. All right. Without flow, there is no effective resistance. In other words, you can have a resistor, in your circuit, but if there's no flow across it, there's no drop in pressure. There's no effect of the resistance. So, flow doesn't create the resistance, but flow creates the effect of the resistance. And if you increase flow, you increase the resistance or the pressure drop. And of course, we said this resistance drops pressure. Everyone thinks resistance decreases flow, but it decreases the pressure gradient, and resistance drops pressure. So for rock, paper, scissors, you've got pressure takes flow takes resistance, and then resistance takes pressure. All right, what is flow? Well, flow is volume of time. Think of it as the number of molecules of air that are moving, through a particular point. Flow is in liters per minute when we're dealing with CPAP or positive airway pressure. And remember, flow is an attempt to equalize pressures. And in any system at one time, there is only one flow. So the law of conservation of mass is what tells us that. So look at the 2 tubes. Q is what engineers use to describe flow of air. We use V dot, which is the first time derivative of volume. But you can see the 2 tubes. Whatever molecule goes in on the left side, the same number of molecules have to come out the other side. That's just it. Now the smaller tube, to have the same flow, is going to have higher velocity because it's got a smaller cross-sectional area. But to have the same flow, realize that. In other words, the smaller tube has more resistance, so you're going to have a higher velocity. It's like putting a nozzle at the end of your garden hose. But at any one time, there is only one flow in a circuit at any given point. In other words, in a CPAP circuit, you could put a flow meter anywhere in the circuit, right there when it comes in the machine by the air filter, on the other side of the fan. You could put it up in the mask. Wherever it is, there's going to be one flow in that circuit. That is, I would say, up to the exhaust. Now, and we'll talk about that in a minute. The other thing about flow is there's 2 types. There's laminar flow and there's turbulent flow. Now, laminar is when they all get along, the molecules, and they move all in the same direction. And you have laminar flow in the distal segments of the lung, okay? But through a CPAP circuit, it's all turbulent flow. And the only exception would be, I guess, if you had a bacterial filter in, and that would create like 2 to 3 centimeters of maybe some laminar flow, but then we go right back to turbulent again. But anyway, if you look at the difference, change in pressure equals flow times resistance, or Ohm's law. That's for laminar flow, the black line, the straight line. It's a linear relationship. But in a CPAP circuit, it's turbulent flow. So change in pressure is equal to the flow squared. V dot is flow, of course, times the resistance. So it's a different equation. And that's very important, very key to what we're going to share in just a little bit. So talking about resistance, and the slide is missing something up here, but when it got transferred over. But in the circuit, everything that's encountered is a resistor, and that's what's missing at the top of my slide. Everything's a resistor. So the fan itself is a resistor. But as the fan spins and translates electrical energy into kinetic energy, generates pressure on the fan blade, which begins the flow, it's going to encounter the flow meter in the machine, which hangs down into the air path until it creates resistance. It's going to go through the humidifier, which doesn't generate much resistance. And then it's going to go down the circuit hose, whether you have a 12 millimeter, a 15 millimeter, or 22 millimeter. The smaller the diameter, the much greater the resistance is in that hose, and the greater the pressure drop. Okay? And a 6-foot hose is going to have 3/5 of the pressure drop that a 10-foot hose is going to have. So in other words, to get 12 over here to the nose, you might have to start with 20 on the fan, depending on what you have in your circuit. Of course, a full face mask is going to have the least resistance. A nasal pillow mask is going to have the most resistance, especially a small cushion a small nasal pillow cushion, because it has a smaller hose. Obviously, the mask hose, they have some of these mask hoses now have 10 millimeter diameter, and that's going to create tremendous resistance. We don't talk about inside the body. The nasal passage is going to create resistance and pressure drop, particularly if they're congested. And of course, it depends what type of mask you're on. Because a Phillips mask, if the large and medium cushion have much more resistance than a ResMed or Fisher-Paykel or React Health mask. And the small cushion, it's about the same. So just by changing the circuit hose, changing the mask, and the cushion size, you could basically change therapy by 6 or 7 centimeters, and and it happens every day in DME offices all over the country because people don't think about this. And also, if you put a Phillips mask with a ResMed machine, you're decreasing therapy even if you use the mask setting, because it's thinking of a ResMed mask. And if you use a ResMed mask with a Phillips device, well, it's got less resistance. So guess what? They're going to get more pressure delivered to the face. And these are what we need to learn. And we can use these differences to optimize therapy to help our patients. Now, we talked about resistance increases with flow. And of course, it's turbulent flow, so it's going to be parabolic. It's going to be curved like this. And what that means is at high flow, you got flow on the x-axis below, and you've got pressure drop, the change in pressure, over on the y-axis. And you can see at high flows, you have a lot of pressure drop out here. But the great news is when they're parabolic and it's turbulent, at low flow, you don't have any pressure drop. And we're going to use that to our advantage to help make CPAP more comfortable for our patients. And that's what the VCOM does. We'll talk about in a bit. So let's talk how this works. On inspiration, there's real high flow because you see the exhaust there in the middle. You've always got to have exhaust because to have pressure, that means you got to have exhaust because the pressure in the circuit, it's what's driving the exhaust. You remember, as the second question we did, patient's pressure went from 13 to 16. Well, their exhaust flow went up because there's more pressure driving that flow. See, the room air is 0. If it's 13 centimeter, the pressure gradient is 13 to 0 going out across through those little holes in the mask. And if it's 16, you got much higher flow. So the exhaust flow is always there. But when you're breathing in, now you have the patient flow that's positive, and it's taking the tidal volume in. So you have maximum flow during inspiration, okay? And therefore, as it crosses all these different resistances, then the IPAP is reduced. During exhalation, what happens is, well, there's no flow going to the patient. The patient's actually exhaling. And then there's less exhaust flow because much of the exhaust flow is coming from the patient. So there's very little circuit flow. And therefore, there's very little pressure drop in the system. And in fact, if you're breathing through a nasal pillow mask or a nasal mask where you have to cross the nasal passage, because of the resistance there, you're going to build back pressure. You're going to build EPAP here in the pharynx and in the lungs. So that's why nasal masks require less pressure, nasal pillow masks require the least. So on inspiration, high flow, big pressure drop. Expiration, low flow, little pressure drop. Now this is a study from Kingman Stroh and Susan Redline. Dr. Redline was actually, I think, a fellow with him at this time at Case Western in '86. Of course, you all know she's at Harvard and just gave the keynote address this year at APSS. So this is a study they did with first generation Philips CPAP, actually Respironics at that time, in 1986. And look over here on the left, you can see that the patient was on 14 centimeters, but these first generation machines couldn't adapt the motor speed quick enough. And so when they breathe in, look, the pressure drops. Now the arrow's been going up, but the pressure is reducing on inspiration, down to about 7 or 8 centimeters. So they're 14 on expiration, but only 7 or 8 on inspiration. And of course, the point to see about this is the fact that they didn't have any respiratory events. Now, when they turned the CPAP off, look, they had 3 apneas right there, but they turned it back on, the apneas went away. So is IPAP really that important? Because it used to drop tremendously with early CPAP devices, and yet we were still effective in treating patients. And the truth of the matter is, it's not as important. Now, you have to have some IPAP in the system, or you'd have that resistance to have to pull air in across. So everyone needs some IPAP. The question is, we're going to talk about this, that you need IPAP less than EPAP. And currently, there's no device on the market where you can do that, at least no mechanical device. There's a way to adapt it. So EPAP is the therapy. Mahadevia showed this first right off the bat in '83, right after Colin Sullivan, that basically if you just supply EPAP, you can treat sleep apnea. You don't need IPAP. In 1990, Dr. Sanders and Nancy Kern at Respironics came out with BiPAP, and we all kind of got sidetracked there, thinking that IPAP greater than EPAP was really the way to go. But Gugger showed in '92 that CPAP at 12 compared to BiPAP at 12/6 made the airway much larger using CAT scan. Morrell showed that expiratory narrowing of the pharyngeal airway prior to obstructive event, it's in expiration. In other words, if you can stabilize the airway during exhalation, you can prevent events. Serres and Mark showed lowering EPAP worsened flow limitation. That if you're dropping EPAP, like with expiratory release programs, you reduce EPAP, you're reducing therapy, period. And of course, Resta showed that EPAP treated respiratory events by itself. IPAP really has no effect. And Tomisier again showed stabilizing the airway and exhalation prevents obstruction. So if you stabilize it through the end of exhalation, from mid-exhalation to the end of exhalation, and when they breathe in, it really doesn't matter. These nasal EPAP devices have come out. Well, they don't have any IPAP. In fact, IPAP is negative. In other words, they breathe it in, room air, just like normal. But when they breathe out, they have to cross the resistor, the one-way resistor in the nose, and that builds back pressure or EPAP behind them. And it can be used to treat mild to moderate cases of sleep apnea. It's very hard to tolerate because you have this huge change of breathing with negative inspiratory and then blowing out against that positive expiratory. And because it's flow dependent, in other words, the more the flow, the higher the EPAP, you get most of the resistance in the very beginning of exhalation when you're trying to get your air out. But at the end of exhalation, which is most critical, there's no flow. So therefore, there's no EPAP. And that's why they can only treat mild cases, because there's no in-expiratory pressure. And, and the fact that they're difficult to get used to. If you can't get used to it and it's effective in treating, well, you did away with a machine and a humidifier and electricity. But we have not been very successful. Of course, we have a sicker, group of patients that are referred to us. We don't get many just, basic snorers that come in that don't have obstructive events. But there are people who would benefit from this. Now, talking about EPAPs as therapy, not IPAP, the Zoo article from Journal of Clinical Sleep Medicine was quite telling. It's a bench study. And, basically, you just decrease EPAP, you just decrease the efficacy of the disease, or the efficacy of the device, to treat the disease. You just can't get past this. There's an EPAP that every airway needs. And if they get that EPAP, they're not going to obstruct. If they don't, they're prone to obstruction. And you can put an expiratory relief in there, but you're just lowering therapy. Hypoglossal nerve stimulators like Inspire and the new Nyxoah device, they fire during mid-exhalation. They have to, because you have to stabilize the airway during mid-exhalation. You see, whether you're stabilizing it with a stimulator to get the muscles to constrict and hold it open, or whether you're stabilizing it with air pressure to split it open, it's the same thing. If we stabilize the airway during expiration, IPAP has little importance. EPAP's also the safety with the PAP therapy. A PAP device has two things, okay? It's got to do two things. It's got to provide therapy, which is increased pharyngeal pressure and FRC. You've got to be able to split and stabilize the airway. Number two, it's got to be able to clear the CO2 or the exhaust from the circuit so the patient doesn't rebreathe, like our question about Dr. Smith. So it's the expiratory pressure that clears the gas. As you are breathing out during exhalation, it's the pressure in the circuit during exhalation that is determining the flow or the intentional leak out the little hose. And so lowering EPAP not only lowers therapy, it increases the risk of rebreathing. IPAP provides little protection from rebreathing. And we're going to be coming out with this in a few months. But at low pressures, a lot of people are rebreathing. And always think about someone who is having trouble tolerating PAP at low pressures. Always think rebreathing. And anytime someone's anxious on PAP, always think of rebreathing, just like Dr. Smith in our question. So let's talk about a more modern history. We talked about on another slide, Dr. Sanders and Dr. Kern at Respironics introducing BiPAP back in 1990. Basically, they had a flow meter and a valve, and they could dump flow during exhalation and drop the pressure. And that's where the theory came out of crack the airway open with EPAP to treat the apneas, then force it open with IPAP to treat hypopneas. And eventually the Academy adopted this as their titration guidelines, and this is where we got sidetracked, and we'll talk more about that. In 95, a good study came out to show BiPAP really had no benefit with adherence over CPAP. Now, we do know now that for COPDers and those who are severely obese, where their work of breathing is a major problem, IPAP is helpful, but those are few cases. And that, by far and away, the majority, 90% or more of the patients, the IPAP actually makes it harder to breathe, increases the work of breathing we were finding. In 2001, they introduced proportional PAP, where during IPAP, the pressure was increased, and during EPAP, the pressure was decreased. And this is the precursor to C-Flex by Respironics 2 years later. And again, in 2003, they introduced C-Flex. ResMed later introduces EPR. C-Flex is flow-based. EPR is basically just a simple BiPAP. The pressure just drops on exhalation, whether 1 to 3 centimeters, depending how you set it. I still remember the ResMed rep, who's now a regional manager, coming to my office in 2003 and telling me that this C-Flex was not good, that it was dropping therapy, and that we shouldn't be ordering it. We should be using their device. And he was right. It's just they came out with EPR a couple of years later. I never heard that again. And I just believe the manufacturers like everyone else. So I put everyone on C-Flex or EPR for the last 20 years. 2010, it gets worse. Philips introduces their mask resistance setting because the engineers were told you've got to maintain that pressure during inspiration. You got to maintain that IPAP. You can't let it drop like these old machines we had in the study with Dr. Stroh and Dr. Redline. You can't let that happen. Well, but we got these nasal pillow masks and they're going to drop pressure. Then you got to jack it up. You got to jack it up when they put that nasal pillow on. So starting in 2010, Philips introduces the mask settings 1 through 5. You put it on the side of the cushion and you enter in the machine. And so when you put a small nasal cushion in, it has more resistance in it. Guess what? It's going to jack that IPAP up even more to overcome the pressure drop that's actually comfortable for the patient. So this is where it happened. ResMed, of course, and the others came out almost immediately, although theirs is just based on a nasal pillow, full-faced, or nasal mask. And if you have a nasal pillow mask, guess what? It's going to jack that pressure up because they're trying to maintain IPAP. And this is where it's fallen apart. It's harder to wear CPAP today than it was 15, 20 years ago. And we've done this, all this focus on IPAP, and I believe for no therapeutic reason other than decrease adherence and make it a more miserable experience for most patients. And then also during this time, the engineers are smart. It's not their fault. They did what they were told. But they figured, hey, instead of having the valve, to change these pressures, we'll use these low inertia turbines. And we now use motor speed control. So, basically, these blowers can instantaneously change pressure just like that. So as soon as it senses a drop in flow, suspecting inspiration, boom, there it goes. And that's why, with nasal pillow mask, you've got that little small hole, so you get jetting. You get this high velocity going into the nose. And so more people are having to wear full face masks because they can't tolerate the nasal pillow because we're jacking the pressure up on inspiration, really for no good reason for the majority of patients. So, and it gets worse. No one's looking inside. When I talk to all the engineers, different manufacturers, and I start talking about nasal resistance and pharyngeal pressure, they go, stop, doc, stop, stop. We don't go there. We just go to the face. We're not allowed to talk about it inside. So, they're delivering that pressure to the face, but they're not realizing there's nasal resistance. It's not the pressure you're giving to the face that's causing the therapy. It's the pressure in the pharynx and in the lung that's causing the therapy. And so the doctors are looking inside and the engineers are looking outside, and no one's looking at both sides. And that's how this was found. So could IPAP lower than EPAP be superior to IPAP greater than EPAP? Currently, there's no machine in the world, ventilator or BiPAP or any device where you can lower IPAP less than EPAP. I won't say there's none because I'm now doing that in my lab with we're testing new algorithms and stuff to develop to make the machines better. But there's nothing commercially available that happens. And basically, older CPAPs had lower IPAP, which was more comfortable, easier to tolerate, and they had higher EPAP, which was more therapy and better safety. The newer ones are the opposite. And what's the consequences of higher IPAP? Well, it's going to lead to increased air velocity. We call it jetting. Remember, this is going to cause discomfort and intolerance. More people are going to go to full face mask because they're going to get nasal symptoms. It's like taking a spray jet and just spraying the inside of their nose. People don't like it. Well, guess what? IPAP causes more leak in mouth openings. And by dropping the IPAP, we found we can reduce chin straps by 85%. It causes abdominal distension and morning problems. If you're jamming air down the lungs, you're jamming it down the esophagus, and that air's got to go somewhere. We found it's leading to treatment emergent central sleep apnea. I'm not really going to cover that much today, but basically, C-Flex comes out in 2003. ResMed follows with EPR. In 2005, we first described Texan, called complex sleep apnea at the time. Increased IPAP causes more drying. It has greater humidification requirements because you're losing more out the exhaust. And it causes more noise with the device. Bottom line is IPAP less than EPAP is a more natural and normal human experience. When I showed this Dr. Keegan-Strode, it goes back to the beginning of our whole experience with PAP with Colin Sullivan. He grabbed this immediately and realized we'd got off course. And he's the one who actually came up with this, that it's a more natural, more normal human experience. Actually, Jerry McGinnis, who's the founder of Respironics, we've been working with kind of while he's in retirement, and he gets this. He sees it too, that they got off track about 25 years ago. It was mainly after BiPAP. How do we lower IPAP less than EPAP? Well, when I thought I figured this out a little over a year ago, I had to think of a way to do it. So I made my first design of the early VCOM back in July of 2021, but it was only 3D printed, so I couldn't put it on patients, just some volunteers. And we were able to drop IPAP but maintain EPAP, and the comfort was obvious to numerous individuals, a lot of executives we showed it to. And then in January, I redesigned it and then began injection molding it during the spring to get all the FDA requirements met. And then I was able to introduce the VCOM at APSS in Charlotte this year, and we began patient use. Of course, since we began patient use, we've got all kind of cool data. What is the VCOM? Well, it's just a simple inline resistor. It's a resistor the machine doesn't know is there. It's non-compensated for, and that's what makes it good. You know it's there. You're putting it in there because you want that effect. You don't want the machine to know. Doesn't require a prescription. And initially, we thought about it as training wheels for CPAP, but now we're finding is no one wants to take it out of their circuit. Once they get used to it, they want it there. And we're finding about 80% of the patients who are already doing well on CPAP, they prefer to have the VCOM in their circuit as well. They like the feel or the decreased noise. It goes right here between the mask hose and the circuit hose, a normal 22 millimeter fitting. And so what's the beauty of it? Well, the beauty is at high flow, you see out here during inspiration, when you're going to have the high flow, you're going to get a big pressure drop. So it's going to drop IPAP. But during exhalation, okay, it's not going to drop much because there's very little flow across it. And therefore, it preserves EPAP. When I showed Chief Medical Officer Phillips this back in March, his first comment's like, oh, so it's like C-Flex. And I'm like, no, C-Flex drops expiratory pressure. VCOM drops inspiratory. Oh, so it's like turning the pressure down. No, if you turn the pressure down, you turn both IPAP and EPAP down. The VCOM drops IPAP to provide comfort, but preserves EPAP to provide therapy. And that's what's key. So as far as experience, I'm using this instead of patient data because we had 300 sleep medicine providers at APSS actually put on CPAP, feel 10 or 12 centimeters, put a VCOM in and feel the difference. And well, I want to say they weren't blown away because of the VCOM. So 92% believe VCOM would help new patients. 96% thought it'd be good for struggling patients. 96% believe it'd be best just to include a VCOM in every setup because almost everyone's going to benefit. And 86% believe that it would decrease phone calls to theirs or their DME offices. This is a home titration study done by Dr. Bob Farney and his group, University of Utah, and they've done multiple of these. This is just one example. But you look on the left, the top tracing is pressure in the mask. We're measuring the mask pressure. It's on the patient side of the VCOM. And you can see the patient's on about 9.5 centimeters, and expiration is the higher part. And then they breathe in, it drops about 0.5 centimeter. Look over here on the right with the VCOM in, you can see they're on expiration about 9.5 centimeters. And when they breathe in, they're dropping to about 7.5 centimeters. And so it's dropping IPAP, preserving EPAP, and the patient had no respiratory events with the VCOM in. In other words, we're dropping IPAP and we're not creating respiratory events. This is on 101 patients, 63 on ResMed, 21 on Philips, and 17 on React Health devices. And these are patients who are all averaging over 6 hours a night and doing well on CPAP. Some have been on a couple of years, particularly with Philips devices, because there weren't any new patients put out on Philips since June of 2021. So anyway, these patients were averaging 7.5 hours. And they did 4 nights without the VCOM. We got the data in 4 nights with the VCOM. And you can see their P90 or P95 isn't changing. In other words, they're on auto PAP and it could adjust, but it didn't change. It didn't change therapy in this 101 patients. But look at the leak. The leak was significantly reduced. In fact, the p-value is 0.0001. And look, the residual index was reduced, and that p-value is 0.001. In other words, when I said it didn't change therapy, it didn't adversely change therapy. But look, it actually improved therapy, particularly with the ResMed devices, because we had so many of them. I mean, in other words, it's helping patients, and these are those who are already doing well on CPAP. So it's not just for beginners necessarily. They want the experience. We also found out sort of accidentally that one of my chief sleep techs put one in instead of a chin strap. First week we were doing them in May in the lab and found it prevented a chin strap. So we started a little trial or case series, and basically we've had 62, and it's prevented a chin strap in 53 of 62 cases by reducing IPAP. So dropping IPAP reduces mouth openings and leak. Treatment emergent, yes, we've had 14 cases, and it resolved all 14 cases of treatment emergent that we had in our lab, 14 consecutive cases. So that's another paper. We have several papers you can see that we're going to be releasing. Other advantages of decreased IPAP, well, the noise. The noise is as much as 20% reduced, depending on the pressure, because the higher the pressure, the more noise in general. And then, of course, humidity loss, is one question we ask. They don't lose their humidity as much. The exhaust that blows on the bed part, the abdominal distension, morning problems, the nasal symptoms, and, of course, decreasing the use of full face masks. You see, let's just be clear. The VCOM is nothing revolutionary. It's just fixing the foolishness that we've had the last 20 years. It's just letting IPAP drop. It's more comfortable. It's more natural. It's going to get more adherence and make people more comfortable. I mean, it's kind of like this. If you had something to give the patient to make them more comfortable and you didn't, you have to really look at your ethics behind it. When we treat chemo patients, we know a certain percentage are going to get nausea. So they all get an antiemetic beforehand. Not all are going to need it, but we give it because why? Why do you want them to get nauseated and feel bad? Why do you want patients to struggle with IPAP where they don't have to initially? And they don't have to get used to the whole inspiratory pressure. They can get used to a smaller amount. They need some. You got to have some IPAP, or you're going to have to overcome the resistance in the system. And what's going to happen is you're going to get more people on nasal pillow masks. And the more people you get on nasal pillow masks, the higher your resupply is going to be. The number one resupply mask for Philips is the Nuance. Okay, and they're discontinuing it. Don't get me started. And the reason it's the number one resupply is because that's the one that people are wearing long term. Okay, the number one resupply for ResMed is likely the P10 because it's their number one selling. And that's because if you get them on a nasal pill, not saying you can't get people on a full face long term, but you got a much better chance of long term adherence if you get them on a nasal pillow mask because they can do so much more, interact with their environment. And using a VCOM will get more people on that. The over-engineering of the last 15 years has made it very difficult for nasal pillow masks, particularly at higher pressures. How could this happen? You got to wonder. Well, and I've interviewed everyone from the first engineers at Philips Respironics at the time, who worked with Jerry McGinnis and Dr. Sanders and all these early physicians like Dr. Farney at Utah, Dr. Stroll at Case Western. They were back there in the early 80s. How did this happen? And they all tend to agree that it's just sort of a disconnect that happened. It was parallel development of ventilators and CPAP machines. One's on one side of the room, one's being made on the other. And we know that BiPAP is the greatest thing really for non-invasive ventilation. I mean, it changed the whole field of non-invasive ventilation, and it decreases the work of breathing to increase IPAP over EPAP, but not for people with normal lung mechanics. That's for people, who are struggling to breathe and have bad lung mechanics or bad lung compliance. But for people who are normal or near normal, it makes it more difficult. And, early on, physicians were working close in the lab with the engineers, but that really hasn't gone on as much in the last 25 years. And so there's that disconnect exists. The other problem is money. There was so much money in BiPAP for sleep disorder breathing because, for every non-invasive ventilation patient, you probably have 30 CPAP patients or 50. And you got to realize that, if a patient failed CPAP for $1,000, now they got a BiPAP for $3,000. So if someone did figure this out, they might have been quiet about it. There's also a perception by us as providers that there's little science in mask selection or PAP circuit, and that CPAP's just a commodity. Oh, put them on CPAP 5 to 20 and let them pick whatever mask they want for comfort. That's what I did. I did that for 28 years until 2 years ago. He came to me. I said, don't talk to me about masks. Talk to my respiratory therapists and sleep techs because they're the ones that make that decision for the patient. Then I think over time, sleep providers and home medical equipment companies, I think we just began trusting the manufacturers' little questions. I mean, I used to call the reps and ask all my technical questions. I don't do that anymore. And I think that's how we got off track. But now we need to get back on track. Sleep Review Magazine, their issue for November, December, their cover story is CPAP pressure relief in the wrong place? And so if you haven't read that article, I recommend you read that. For the future, well, beginning now, as sleep medicine providers, respiratory therapists, sleep physicians, sleep techs, nurse practitioners, PAs, everyone who's taking care of these patients, we need to take control of the PAP circuit, just like we do a vent in the ICU. We would never let this happen in the ICU, but we don't equate it, but a PAP is a vent. And we need to find out how to lower IPAP less than EPAP. Well, eventually my little device is going to be obsoleted. In fact, I've already obsoleted it with technology and put on the machines, but it's going to take 1.5 years, 2 years, to get all that done. So for right now, we reverse the foolishness by putting a VCOM in the circuit. And so we need to lower IPAP less than EPAP. And that's the only way to do it right now. We need to focus on pharyngeal pressure and FRC, not set pressures. And we need to understand everything in the circuit that's altering those settings and understand about resistance and flow and looking at those and understanding pressure drop to take better care of our patients. Look, the algorithms are coming. I've got them here on my whiteboard and we're working on them. But for now, the VCOM's a quick, simple, safe, inexpensive fix, and it works on any device. Any questions?
All right. Hello, Dr. Noah, and for all the attendees of our JSM CEU event, welcome, and thank you for taking the time to share your expertise. And it's really stimulated a lot of questions from the attendees, and I want to go ahead and get into that. But just to introduce myself, Justin Owens with Medical Service Company, Vice President of Business Development, and we're here with Dr. Noah. And thank you again. We'll go ahead and jump into the questions here. So the first question is, when do we need to start titrating the initial CPAP pressure? How do we know it is time for titration?
I'm not sure I quite understand the question. When do we need to titrate? Could they elaborate?
So we didn't get any elaboration. So maybe if the second part of it, how do we know it is time for titration? If there's any feedback you give in that, if you need more info, we could always move on to the next question if that would help.
I really need more info. Obviously, patients are either being titrated in the lab or they're titrated at home with an auto algorithm. So everyone needs a titration at some point to get to the therapeutic part. But let's move on to the next one. Might make more sense.
Sounds good. So it's a comment/question. Couldn't the VCOM just be installed inside the PAP device just prior to the output connector on the unit?
Well, the VCOM, you actually can put it between the circuit hose and the machine, but most of them have a specific attachment. So it's best to put it between the hose and the mask hose. You don't want it like with a full face mask. We sometimes put an extension so it's not right up at the swivel, but it's better to keep it further out. But right, as long as it's between the machine and the exhaust in the mask. That's and of course, eventually it'll be built into the algorithm. In other words, the stuff that's been added on for the last 20 years, we'll get rid of that. And actually, we in our lab here, we're working on new algorithms of supplying the pressure in a way that's really unique and different. That's going to make it much more comfortable. Basically, in the interim, the VCOM is there just to fix what's kind of been broken.
Yeah, no, thank you for speaking to that, and definitely learning a lot through the presentation as you talk through, common beliefs and just some things that are helpful for people to be aware of versus just making some assumptions with the enhancements and the therapy and the changes over time. So the next question: can positive pressure sleep therapy in COPD patients promote increased chronic CO2 retention?
Um, well, actually, the positive pressure is going to increase minute ventilation. It's going to increase tidal volumes, especially in patients with significant COPD. That's where you want IPAP greater than EPAP too, because their work of breathing and their lung mechanics are bad. So those are the 3-4% of patients that really need IPAP. Now, what we found is they still prefer the VCOM because they like the flow pattern of the VCOM, but they still need the IPAP. They just don't want a square wave. Is that what it's giving currently? And of course, if you're anytime you're on a PAP device, you're more prone to rebreathe CO2. And if you're already someone who's retaining CO2, then that becomes a bigger issue because you have more CO2 to clear when you're exhaling. So, good question.
Well, and to tie into the conversation about VCOM, there was a question: is a prescription required for VCOM?
It's not. Initially, there was some confusion on this because you have to have a prescription for CPAP. Okay. So as long as the person already has a prescription for CPAP, the VCOM doesn't need any extra prescription in any way. That it's an accessory to therapy. It's only for comfort. There's no therapeutic claims at this time. So that may be coming with all the data and some I presented here tonight. But currently, it's for comfort. And again, comfort is something that doesn't need a randomized trial. It's something that, look, this is more comfortable. You give, like the chemo patients, you give them Zofran, you give them Tylenol, even though there's no study to show, it really makes a difference. But if it helps, if someone says, look, this is more comfortable, which 96% of new patients do, why would you make them suffer without it? Especially that that the machine's been engineered to make it harder. So it's a short-term fix. Eventually, the machines will be fixed. That's pretty clear. As you know, if you all read the sleep review, the cover story for Sleep Review magazine is available online as of yesterday. In fact, this morning there's already a couple posts on the Academy Forum, American Academy of Sleep Medicine Forum. The president of the Kentucky Sleep Society and a former president of APOS have already commented about putting it on all their patients. So it's going to start getting around. The article is really interesting because it's not really me; it's other pioneers in the field who are really saying the same thing. So I recommend everyone go to Sleep Review magazine to their website and read the article. I think that'll help.
Thanks, Dr. Noah. And I know timing-wise, we're getting close to the end of the session. Out of respect to your time that you've been so grateful to give us and keeping the JSM forum moving along, wanted to thank you for your time, your expertise, your guidance on some resources that people can access to learn a little bit more about this. And there was one more question that came in, and then we can wrap it up from there. But to tie into the last one of how do we get VCOM to give to our patients? So just access, any guidance on that for the attendees?
Very good question. You just if you're with a DME, just just order them. We've had I think what's going to happen is doctors are going to start demanding them for all their patients in the interim. And you know, uh, if you go to sleepres.com, you can find, if you're with me, you can find how to get those. Most of the nationals we're in close conversations with. I think the thing you have to do is just demand them for your patients. Say, I want the most comfortable experience for them, and just go for it. Be the advocate.
Perfect. Well, Well, thank you, Dr. Noah. Appreciate your time again today. Definitely very good information that was shared. We appreciate you being a part of the JSM CEU event this year, and appreciate your time. Hopefully, you have a great rest of your day. And for the attendees, we'll be transitioning over to our keynote presentation. So looking forward to seeing everybody on the other side for our keynote. So thank you again, Dr. Noah. Have a great rest of your day.
All right, guys. Thank you all for listening.